That's my cue. Okay, good morning. Well, I just wanted to welcome everyone here in person and on Zoom to our 10th annual, it's a good milestone, annual Fellowship Research Day. I'm Tashani Alangasekra. I direct the Grand Rounds program, and I also have the distinct honor of being the mentor for the fellowship college, the OBGYN Fellowship College, which is a really wonderful program where I get to know these amazing fellows over the course of their many additional years of training that they're getting here with us. And so we just are, this is the start of a celebratory process as we send you on to your hopefully final grown-up adult jobs. And so this is really just a celebration of the work and the hard effort and the dedication that you've put in here at UCSF and for our department. And so we're just so proud of you. And I'm sure you're going to get a lot more of that over the course of the morning. But to start, as is our tradition, we always have a keynote speaker. And I am just so pleased, and it's my distinct honor to introduce Dr. Dominika Seidman, who is a physician scientist and advocate whose work sits in the intersection of clinical care, research, and health equity. Dr. Seidman is an associate professor in the Department of Obstetrics and Gynecology and Reproductive Sciences at UCSF, and she's an attending physician at Zuckerberg San Francisco General Hospital, where she provides care to some of the city's most underserved communities. Dr. Seidman received her medical degree at Harvard Medical School and completed her residency at Northwestern, and did not one but two fellowships. So that could be all of your futures also, and yours as well, to our residents at UCSF in reproductive infectious disease and family planning. Dr. Seidman's research focuses on HIV prevention and reproductive health, and she has led innovative studies on pre-exposure prophylaxis, exploring how to best integrate HIV prevention into reproductive health services in ways that are person-centered, equitable, and sustainable. Her collaborative work spans public health, behavioral science, and implementation science, and she's widely recognized for her thoughtful, community-engaged approach. In addition to her academic and clinical roles, Dr. Seidman serves as the director of Team Lily, which is a multidisciplinary program at San Francisco General Hospital. Team Lily provides person-centered, trauma-informed wraparound services to pregnant and postpartum individuals facing significant barriers. I lost myself. Significant barriers to accessing clinic-based prenatal care, including homelessness, substance use disorders, incarceration, intimate partner violence, and mental illness. The program strives to ensure that pregnancy, birth, abortion, and postpartum experiences are filled with dignity, grounded in autonomy, and aligned with individual parenting goals. Beyond her academic and clinical achievement, Dr. Seidman is known for her deep commitment to mentorship, advocacy, and helping to shape the next generation of leaders in global women's health. I'm so pleased to call Nika a friend and a co-parent in my resident family, the best family. Before I finish, I'm going to do my other job, which is to mention our important land acknowledgement to the Ramaytush Ohlone people, who are the traditional custodians of this land. If you like to read more about the Ramaytush Ohlone people, we have some links here for you to review. And without further ado, I'm excited to present Dr. Dominika Seidman.
Good morning, everyone. Tushani promised me a brief introduction, and that was not brief. So she is already in trouble as my co-mother of our amazing resident family. Okay, I am so pleased to be here with you. Congratulations. Before I get started and before I forget, I wanted to thank two people. Number one, Tushani, because this came together, many of you know, as the last minute, and Tushani was so graceful and kind to our original speaker and to me, and so thank you for extending that grace to us. And Patrick, thank you for dealing with me at like 3 o'clock in the morning with my slides and my having not the right number of learning objectives and all those kinds of things. Okay, so today we're going to be talking about my personal experience in research, trying to, first of all, convince you all to do a second fellowship, and second of all, to just share some of my experiences on my research journey and some of the reflections I've had along the way. I don't have any financial disclosures. My only disclosure is that on Sunday, instead of preparing for this talk, I went on a Mother's Day hike. And I share that because I think part of my goal of this talk is to be transparent about how we integrate the different aspects of our lives, recognizing that at some points we're doing a lot of research and some points we're doing less research, but there are ways to integrate it throughout your career. And I think particularly in this political moment, especially for those of us who are clinicians, it is essential for us to do so because we are privileged to be in positions where we are going to have stable funding from some component, and we really need to not only do research for our patients, but also to help mentor future generations of scientists. Okay. So again, I promised you transparency. My path in research has not at all been linear. And I came to San Francisco to do my first fellowship in reproductive infectious disease. I arrived here and my mentor was Dr. Deb Cohan, who's on the left, who is an amazing physician scientist. And shortly after I got here, Deb was diagnosed with breast cancer, and my fellowship turned into learning how to take over and be the medical director of the HIV clinic, which is the clinic for patients affected by HIV in pregnancy and HIV prevention. I say that with so much gratitude because what I learned from that was that no, this was not a fellowship that was a research year, and it founded almost all of my clinical questions that drove my future research. When I got there, HIV was doing some things that were a little outside of the box. In the middle, you'll see Shannon Weber, who is a social worker, and she was the director of HIV. And Shannon is a fierce advocate for sexual health services. And she had Deb had started giving PrEP for HIV prevention to people in pregnancy way early. So if any of you remember, PrEP for HIV prevention was approved by the FDA in 2012. I started fellowship in 2013. They already had a very large number of pregnant people on PrEP. So this was like, whoa. And then Shannon and Deb had me step in to do some of Deb's talks. And Deb's talks were not only about giving PrEP to pregnant people, but also about how we might think about talking about breastfeeding and lactation with people living with HIV. At that time, that was extremely radical in settings that were high resourced. And actually the guidelines for perinatal HIV transmission in the US only just changed a couple of years ago, talking about how we can offer and discuss with our patients breastfeeding, lactation in the setting of living with HIV. And so they were decades ahead of their time. And I think what I would highlight about these pieces is that when you are in clinical situations and you're A, noting controversy, or B, noting no guidelines to guide your clinical care, that is where your clinical research questions come up. The person on the far right is Dawn Smith. She unfortunately passed away and was an amazing researcher at the CDC that was a huge advocate specifically for women and cisgender women and PrEP. And I'll talk a little bit more about her in a second, but I wanted to mention her and put her up on this slide because really it was Shannon and Deb who introduced me to people like Dawn, who really allowed me to kind of push my research questions forward and connected me to people and got me into places where I could actually do those types of research. Okay, so as I said, I got to HIV Clinic and we were offering PrEP to all of these people. And here is my transparent piece of information number one. I came to fellowship, I think maybe having published one abstract, definitely no papers. And I learned quickly. And so for those of you who are residents who are not yet publishing, you can still have long research careers. each kind of moment in your educational journey has its time for different things. And for me, fellowship was a time to learn to do research. This paper was one of the papers that came out of my time at Hive. We looked at all of the pregnant people who we had who were taking PrEP and followed them through their clinical journeys. We worked with a group in New York City that was led by a midwife, Tess Timoney, and Rodney Wright, who's an MFM, and together we shared our patients, and we published it in AJOG because no one had written about giving PrEP in pregnancy. And as I was seeing all of these patients who were on PrEP in pregnancy, I was looking at the guidelines. I did see that all of these different reproductive and sexual health organizations had statements about PrEP and the importance of HIV prevention. However, when I was looking at my community, in terms of my professional community in the women's health field and the sexual and reproductive health field, I really wasn't seeing anyone talking about PrEP. And so that led to kind of the first arm of the way that I thought about research was to understand why are providers not talking about PrEP. And this was a really simple study that we did in 2016, looking at providers around the country who identified as family planning clinicians. And we found, not surprisingly, that only a third had ever even seen the PrEP guidelines. So how could they talk to their patients about PrEP if they didn't even know that these existed? From that, we did focus groups with family planning providers. Shannon pushed me to write opinion pieces with her. The one on the left, our figure got on the cover of OBGYN, and I say that not out of pride. This was totally Shannon's artwork, and Shannon's pushing me to do it. But again, from a place of humility and transparency. Do you know how many places we submitted this opinion piece to? 20 gazillion. And they were all HIV journals. And we got rejected and rejected and rejected. And then we submitted to OBGYN, the Green Journal, and they said yes. And why was that? Because we didn't know our audience. Because I'm an OBGYN and I talk to other women's health clinicians. I didn't know how to talk to HIV providers or how to write to them. And so again, one of the themes of this talk that I wanted to encourage is that writing opinion pieces and commentaries takes a lot of time and is worth it. And you have to know your audience. In addition to that, as I said, we did focus group with family planning providers. We wrote opinions in contraception. And the goal of all of this was trying to increase the conversation about PrEP for HIV prevention for women. Okay, so my reflections from fellowship number one are to think about, investigate things that you can't find evidence for, and particularly things that are controversial. The second thing I would say are to, if you're not sure what your research question is yet, to give talks about it. In those years, I gave so many clinical talks about how to prescribe PrEP. They were very nitty gritty, and I was actually just talking to Tushani. Unless you get in the weeds with people, understanding what are their barriers, you're not going to be able to identify exactly what it is that they need to move forward. And I learned so much going to clinical conferences and talking to people about how we could help integrate this important HIV prevention method into their practice. As I said, opinion writing takes a really long time, and I think it's worth it. It really makes you think hard about a topic that you care about. And then the last piece is I definitely learned that working with people who have a different lens is critical. And I'd also really encourage you to work with people who you enjoy working with. I wanted to give a huge shout out to Shannon Weber. As I mentioned, Shannon is a social worker, and Shannon, more than anything, is an advocate. She would take me to these HIV prevention conferences, and she knew everybody, and she was talking to everybody about, yes, you're doing these PrEP studies, but what are you doing for women? How are you helping women? And when she went to these conferences, Shannon is extremely creative. She would identify people who she saw as advocates, and she would give them a cape. So you can see here all of these different people with capes. So up on the top left is Dawn Smith, the CDC leader in a gold cape. On the right is Dazon Dixon. She's the founder of Sister Love in Atlanta, the reproductive justice organization, who has done tremendous work for women in PrEP. If you look down at the bottom, you'll see people from San Francisco, Al Liu, Oni Blackstraw, who he later wrote an opinion article with. You see people walking around these conferences in capes. And these HIV conferences are so serious, but it was hilarious because people would just be walking around with their sparkly capes. And when I was looking through Shannon's photos of these people in capes, I laughed at this one in the middle. There's a picture of Anthony Fauci with Judy Auerbach that's from way back. And I love that Dr. Fauci is not caped, but Judy Auerbach, who is an amazing qualitative researcher and also has done so much for us to understand what motivates individuals to take PrEP, is the caped person in that picture. Okay, so I decided to do a second fellowship for a lot of different reasons. First and foremost, because I really wanted to become a skilled abortion provider. That was really important to me personally and professionally. And because I really believed that I needed to understand the reproductive health world better in order to think about how to merge these worlds that I was seeing, sexual and reproductive health services. If I was a caper, if I had the skill to make capes, I would cape everybody on this screen. They were tremendously important, and I'm so grateful for them for helping me in this fellowship journey. And what I did in the second fellowship was continue to focus on HIV prevention and PrEP specifically more in the family planning setting. And here I focused more on the client side. And at that time, we were just starting to have data come out looking at these kind of graphs that looked at who was eligible for PrEP. Now, the framing on PrEP thankfully has changed, but at that time, the CDC had very strict guidelines about who was eligible and not eligible for PrEP. And what you'll see on the left was a graph of MSM, men who have sex with men, people who inject drugs, men who have sex with women, and women who have sex with men. Don Smith was one of the really smart people who pushed people to look at that graph in another way, because if you looked at the graph on the far left, you would never invest or think about why women might need or want PrEP. She encouraged people to look as well in absolute numbers and show that actually there are a lot of eligible women who might need and want PrEP. And that really built momentum and motivation for people to think about women as well. On the right, at the time, people were starting to think about a cascade of who might be eligible for PrEP. And then we would think about, okay, if you're eligible for PrEP, how would you identify them? Okay, you might be screened, then you might be identified, then you might be offered, then you might start PrEP, and some of those people might continue it. At that time, we knew that only about 19,000 women had ever been prescribed PrEP, which was extremely low. And so that's where I focused my fellowship research project. We surveyed almost 2,000 patients presenting to family planning clinics in the Bay Area, and not surprisingly found that none of those patients had ever heard about PrEP, or at least a very small number. To me, the finding that was most important, though, was the finding that didn't make it in the paper, which was that patients who were exclusively seen in reproductive health settings and often family planning clinics were much less likely to have heard about PrEP. So really, it was an opportunity to show us that we as family planning providers had a responsibility to offer PrEP and talk about PrEP to these individuals, and there was work to be done. Okay. At that time, what I felt really lucky to do was, again, my worlds were kind of in these different places, and I was going to these HIV prevention, these HIV conferences. They were talking about one thing, and I was going to these women's health and reproductive health conferences, and they were talking about another thing. And in between, I felt like there was these really important ideas that weren't being connected across these silos. So again, I wanted to go back to this PrEP cascade for a moment and talk about what we had learned. In the HIV world, what we had learned was that we really were doing a terrible job identifying, in particular, cisgender women who were eligible and might be interested in taking PrEP. I did want to pause for a second and just highlight, at that time, when we were talking about women, we were talking about all women, cis and gender diverse women. Thankfully, now we have gotten better data and have been able to think about more tailored approaches. But at this time, basically nobody was taking PrEP in the world of women, and so they were kind of lumped together. And what we were talking about in the HIV world was that, wow, this idea of screening, in particular, when we think about things like trauma and domestic violence and IPV, screening maybe is not the right approach when we are thinking about how to provide education and resources to people who might have a stigmatized condition. And so I wanted to highlight in particular the IPV world because they did some of the groundbreaking work showing that when you screen people for IPV and then you give them information, you're going to miss a lot of people. What they recommended was to turn that process on its head and offer information to everybody and then say, would you like more? When they did that, they showed that a lot more people for whom the information might be applicable got the information that they need and were better connected to resources. So we took that thinking and then applied it to HIV prevention and realized that, hey, wait a second, we're screening all these cisgender women in often these very stigmatizing ways. How many sex partners do you have? Does your partner have syphilis? Does your partner inject drugs? Things that A, are stigmatized, and B, people didn't know the answer to, because there's lots of data that shows that people don't know the behaviors of their sex partners. And we recognized that we were missing a lot of people that way. So what about if we flipped that around and offered information about PrEP to everyone? When we started talking about this, and I started giving a lot of talks about this, Shannon and I did a lot of thinking about this, as did a lot of advocates in the HIV prevention world. People like Don Smith thought we were absolutely nuts because that was totally impractical, and we could not spend our busy clinical days giving information to people without screening them first. So what we had to do was to come up practical ways to do it. And I wanted to give a shout out to all of the different advocacy organizations in different cities that did this in a variety of different, very creative ways. On the far right is an organization in DC. In the middle were billboards that were done in Chicago that were really beautiful and very large and somewhat provocative photos of lots of different people who might be interested in taking PrEP. And on the left is the New York City campaign. In San Francisco, we just made a little palm card that we could give out to people, everybody, and say, here, this is PrEP. If you want to talk about it, here you go, because we did not have a big budget. But the point being that we were trying to think about, in response to Don's reasonable question, how could we operationalize universal education? Okay. And after talking about it and talking about it and talking about it, I was so happy in 2021, they finally changed the guidelines and recommended talking about PrEP to every sexually active adult and adolescent, trying to really utilize this concept of universal education. They didn't call it such, but you could really see the threads of the advocacy over the years. And it was incredibly rewarding, especially after we heard no, 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 no for so long, to see the utility of it in the guidelines. And so I kept these pictures up here again, because I think a lot of these organizations push that work forward without getting credit. Okay. At the same time, in the world of HIV prevention, PrEP options were expanding. It was really exciting. There was a ring that was shown to be effective. Injectables were starting to become tested and shown to be effective, and people were talking even about implants. And the conversation was moving very quickly towards, okay, well, people are obviously going to get on the most effective method for HIV prevention. Does that sound familiar to anyone in the reproductive health world, right? So I had the opportunity to kind of think about and cross those silos again, because in the family planning world, we had spent a lot of time talking about and reflecting on our own missteps about how we had recommended things like LARCs, long-acting reversible contraceptives, to everybody because they were most effective, and not understanding people's priorities and preferences. And so with that information, I had the opportunity to kind of share with the HIV community more about what we had learned in the family planning sphere and how that might be applicable applicable to PrEP. I'm not going to go into this study design, but just to say that the REACH study design, which is a really elegant study, if anyone's ever interested in it, showing how patients' preferences really matter just as much as things like effectiveness, in prevention methods. Okay. When we think about when someone has options and they are able to make a decision about a variety of different options to make a decision that's best for them, the field of family planning has really worked towards a counseling approach that's focused on shared decision making. I wanted to highlight Christine Dellendorf, who did a lot of the initial research focused on how that contraceptive offering and counseling might be done in clinical settings and the evidence for it. And she helped me think a lot about how that might be applied to PrEP for HIV prevention. I wanted to also just show, again, this is another moment as a reflection, so much gratitude to Christine as a research mentor, who really took care of me as a student and a fellow, and as someone who sometimes I needed a break. She would never say, this is late. She would always say, this is right on time. She would give me comments and be so supportive. And one of my lessons learned from working with Christine is to surround yourself not only with people who are pushing you and are making you think, but also people who care about you and support you. So when we started thinking about applying this concept of shared decision making to HIV prevention, again, we got into that realm of how are we going to operationalize that? Well, Christine had just done this really cool study that looked at a tablet that developed a decision support tool focused on contraceptive options and showed that it was effective in family planning settings. So we said, okay, what would it look like to develop a decision support tool for HIV prevention options, of which PrEP was one of them? So in my, towards the end of my fellowship, as part of my global health rotation, which I don't think exists anymore, we developed a prototype for a decision support tool focused on PrEP in Kenya and South Africa. And you can see the pictures on the right. And the goal was to, first of all, talk about all different types of HIV prevention options with a focus on PrEP because people didn't know about it. And we knew we needed to provide more information on that specific HIV prevention option for people to show any type of interest in it. I learned so much from that project. We did iterative feedback, we did focus groups with clients and got lots of information about how people wanted stories and how people wanted colors to make this information more appealing. Which is going to kind of lead me to the next step, but I did want to pause and just kind of, again, highlight some reflections from my family planning fellowship, which were, first of all, that concept of taking things that you learned from other parts of your life and applying them to your subspecialty. That allows you, first of all, I thought it was really interesting and it helped me kind of integrate the things I was hearing in different spaces. And second of all, it gives you opportunity, I think, to do some more innovative work. Second thing, this is an ongoing theme, say yes to talks. Giving talks for me has always been an opportunity to share some ideas, get some feedback, and try to develop my thinking and develop relationships that in future could be either co-writers on an opinion or a research collaborative. And then lastly, again, continuing to think with people who have different lenses from you and who make the work fun. Okay. Next for me was doing the WRHR, which is a K award. It's a career development award. I wanted to appreciate very much Vanessa Jacoby, who stuck with me through my K. And for me, the WRHR was such a gift. And the WRHR during COVID was complicated in all of the ways that COVID is complicated. I'm not going to get into that, but what I did want to say was that even when your career has these twists and turns and when COVID is thrown at you, it is okay. If you have to step back or slow down from research for a little bit, you can pick it up later. My career shows that in many different ways. So what did we do during COVID? Well, first of all, we took, and what did I do, during my WRHR? The focus of my WRHR was to think about those decision support tools that we talked about, specifically the decision support tool for HIV prevention, and to test it. We worked with a group in South Africa to do a randomized control trial in Johannesburg, looking at offering the decision support tool to patients who are coming in for reproductive health services at a public clinic. And we showed that this was a very different setting from the United States, because you can see on the left that everybody started PrEP. But B, when we looked at who continued their PrEP for HIV prevention, a larger group of people who looked at the decision support tool continued PrEP. Granted, that number was way lower than those who started, but there was a difference, and this was an RCT, and this was happening in the midst of COVID, of electricity outages, of riots around the clinic. Lesson number 1 through 10 that I learned from this study is that doing research in studies, in places, even where there is research infrastructure, but this was a public health setting, this was not a specific research clinic, is really hard, and it takes time, and your results and your trial is going to be messy. Okay, so from that work, we wanted to think about, so this decision support tool worked in South Africa, in a sense. It offered people information, it was universal education, and it seemed to give people enough information for some group of people to continue the medication longer than others. What would it look like to do that in the United States? So we adopted that decision support tool to be applicable in Florida. So for those of you who know Florida, I was not a Floridian, but I've learned a lot about Florida. We worked with a public health clinic in Duval County, which you can see up here. There you go. Duval County has one of the highest incidence rates of cisgender, among cisgender women, of HIV in the United States. It is super duper duper high. And what I've learned over time from my colleagues there is that is for so many different reasons. And in this public health department there, they were working really hard on a gazillion different things and not so much about HIV prevention. And they were really motivated to work on this project with us. So to make a very long story short, we wrote an R01, and that was specifically looking at how to offer PrEP for HIV prevention to cisgender women coming to family planning clinics in Duval County. And the trial had a couple of different arms. First of all, we were going to do a randomized control trial of that decision support tool. Second of all, we were going to think more deeply about, is it just about the offering of information of PrEP, or is it more about how the counseling is provided? And so we did, as aim 2, a provider level intervention, doing training on shared decision-making, as well as a clinic level intervention of training in trauma-informed care to understand if A, the counseling, and B, the clinical environment affects how people decide to use prevention methods or not. If I was going to have another group of capes, it would be for everybody on this screen. These individuals, Dr. Rachel Logan, Whitney Wilson, Sarah Wolf, and then this individual I'm using to represent our huge team in Florida. She made a t-shirt for herself that says PrEP in the name of love, which is way more creative than anyone than we could have thought of. They made this project happen. Again, this was during COVID. Duval County was hit by hurricanes. Duval County was hit pretty hard by Mpox. Duval County had an insanely high turnover among people who worked in their public health department because people who were underpaid. And this team got the work done, and it was really, really amazing and honestly really hard. What we found was in aim 1 that the decision support tool increased knowledge of PrEP among women quite significantly. And we are currently analyzing aim 2, the intervention, looking at provider and clinic level interventions. Just to say, we started this work in 2017 to 2018. It's now 2025. All of those delays were due to COVID. So just to know, the COVID delays were real and really hard. And during that time, I had the privilege and the honor to build a professional relationship with Dr. Rachel Logan, who I wanted to highlight, again, that theme of when your research is on pause or you can't, just your research isn't working, to think about opinion pieces. She and I wrote this paper on reimagining PrEP for HIV provision in the United States. Again, really thinking about how this is about much more than a pill or an injection or a shot, that we need to think about how we are providing sexual and reproductive health services. That one of the reasons that family planning providers and reproductive health providers in general are not asking people about PrEP and talking to people about PrEP is because they don't feel comfortable about it. And what was that about, and how could we change that? I also really wanted to highlight Rachel because she is an incredible qualitative researcher and an incredible writer, who is a researcher with a capital R, but who writes to clinicians. Her work is incredibly accessible, and she is going to do incredible things. She focuses mainly on health services for cisgender women in the southeastern United States, and I would highly recommend looking out for her work in future because it's going to be awesome. Okay, so reflections from the WRHR. First of all, working with organizations, and by this I mean the Duval County Department of Public Health, working at the clinic in Johannesburg, and particularly organizations that haven't worked with the NIH before, is really, really hard. It's slow, it's challenging, and it is very hard to get things done on NIH timelines. That's not to say it's not worth it. I think it's just I did not go in with my eyes wide open. In addition, during those hard times, the things for me that kept me going were continuing to think and write with people who thought differently. Rachel was a really good example of that. And then Christine supporting us in our work, no matter what the bumps we had along the way. Okay. So I said I did 2 fellowships, and I just have to be honest that I feel like I have effectively done a 3rd fellowship. The addiction medicine people tried to convince me I needed another fellowship, and my husband would have divorced me had I done that. He said I was too old, I needed to have a real salary. All of those things were actually true. But my point is that for me, continuing to learn about things that are new and different and exciting is really what keeps me invested in my career and curious in my career. And so this was kind of another branch point that happened after, kind of during the WRHR and moving on into after it. So how did this come about? In 2017, when I was looking back at slides, Shannon and I gave HIV Grand Rounds that was talking about this really cool thing that we had seen at a talk from New York City. New York City was talking about this concept of status neutral approaches to biomedical prevention. So what that means is an individual would walk into a clinic, sorry, I forgot about my microphone, would walk into a clinic, and if they were HIV negative, they'd be offered PrEP, and if they were HIV positive, they'd be offered treatment, and they were treated the same. That was totally different than in the past, when we were treating people with HIV as this very special population, which in some ways was good. They were getting extra services, but in many ways was bad because it led to stigma and discrimination. Okay, so we thought about that, but that was like a very biomedical and like medication focused approach. What we started asking about was, what would it look like to apply those comprehensive services that were offered to people with HIV to people who were HIV negative? And what would it look like to think about a psychosocial status neutral approach to services? We were having those conversations again in Hive, the perinatal HIV clinic at San Francisco General, Solid Start, and the Department of Public Health. And at that time, in the Family Birth Center, we were also seeing an eclipse of a couple of different things. Number one, the housing crisis was going off scale. So we were seeing more and more people experiencing homelessness. Number two, fentanyl was starting to hit San Francisco, as what were methamphetamines. And so we were seeing more and more people with substance use come in. And big picture, what that led to, it was a lot of people coming into San Francisco General who had no prenatal care. Maybe they had touched the healthcare system in the emergency room or in urgent care or maybe at a harm reduction clinic, but they really hadn't received any perinatal services. And when they were coming to the birth center, and our birth center really identifies as a safety net, we were struggling to take care of them because we didn't know how to take care of them. People were withdrawing in labor, and we didn't know how to treat their withdrawal symptoms. We did not have emergency ways to get people into housing. We didn't know how to treat people's significant mental illness that was unmasked by their methamphetamine use. And what that led to was people having really traumatic births, our social workers coming in after birth and leading to kind of immediate removal of babies. And it was just a really, really hard time, is a way to summarize it. And I think from that, we were also seeing that there were patients who were living with HIV who had many of similar barriers to care, who were actually getting prenatal care and having beautiful births. So the question was, how could we expand those services to other people? That's simplifying a story, but that was kind of our thinking. And we worked very closely with organizations like Street Medicine and the Department of Public Health and Public Health Nursing to think about what might it look like to provide those services that had been provided to people with HIV to people not living with HIV. And that's really where Team Lily was born. That was in 2018. It was started as a pilot. I wanted to, again, in kind of the mode of appreciation, really appreciate San Francisco General for supporting us to just try something and see what happened. And it took off, and much quicker than we thought, because there were many more patients than we understood. Okay, so Tushani already mentioned who Team Lily is. Up on the top are our social workers and navigators. Our clinic manager, Cynthia Gutierrez. Shauna Kim is our therapist. Teresa and Kendra are the navigators. Sandra and Becca are the social workers. And they are really the lifeblood of our program. We provide trauma-informed wraparound services to pregnant people facing barriers to care. One of the key parts of our clinic is called an open access clinic, which we adopted from homelessness services, which many of you who are second years have experienced. And what we're trying to do is kind of make our clinic-based experience a one-stop shop for substance use treatment, mental health services, wraparound, community and social supports, and then continue that work during the week through our navigation and social work services. Through that work, we work really closely with community organizations and public health nursing and street medicine. Okay. Tushani read a little bit from our mission statement, so I'm going to skip that. But I wanted to talk about our approach for a second, because this sounds like a clinical program, but I wanted to highlight how many aspects of it really integrate themes of the work that I had learned in fellowship. So first of all, meeting people where they are, offering a consistent team that communicates across silos. And again, those silos that we had seen in research apply also to clinical care, as you all know. Listening for and trusting people's priorities, using shared decision-making to understand what people want to do when. Also using universal education, making sure people know about all of the prevention options we have to offer. And finally, making sure we're always offering options and choices. Okay. So again, I mentioned when we started this program, we really had no idea who our patients and clients would be. And very quickly, we found out that reproductive infectious disease actually applied very nicely to this work, because about 40% of our patients had hepatitis C and 10% of our patients had syphilis. So early on, this led to an opportunity to continue research. And I wanted to shout out one of our graduates, Christine, who wrote this fantastic paper with a lot of other colleagues on this who are from UCSF, who you'll recognize, that was about breastfeeding initiation with hepatitis C in the United States. And what I really wanted to appreciate about this paper is that, yes, it talked about breastfeeding people with hep C, but it allowed us an opportunity to advocate for how to move the field forward. And I think it did it in two important ways. Number one was to name that people with substance use disorder, particularly pregnant people with substance use disorder, need wraparound services. It cannot just be this siloed substance use clinic. off in the middle of nowhere. It needs to be co-located with prenatal care, substance use treatment, and mental health services. And we frame that around that's how we can help people with lactation support, but it was also true for all of their care. The other piece, and this is the piece that directly relates to research, is that we were able to call out the AASLD, the American Association, can't remember, the Liver Disease Society, for writing these beautiful guidelines that incorporated pregnancy and talking about hepatitis C in pregnancy, but they said nothing about lactation. They totally forgot about that important concept. And so when they didn't do that, what that led to was that all of the studies, we now have some really important studies looking at hepatitis C treatment during pregnancy, but there is nothing on lactation. And Catherine Chappell, the speaker who was supposed to be here today, is just a warrior in her fight to integrate and think about how to provide hep C treatment to pregnant and postpartum people. She's done the studies in pregnancy. We're actually working on potentially collaborating on some of that work in breastfeeding and lactation. And a lot of that and the need for that, having this citation was really helpful because we're able to both tell the guideline organizations, hey, you guys need to think about this, and then B, tell research organizations and funders, hey, this is really important because these people are going to be breastfeeding and need to know if these treatments are safe in lactation. So thank you, Christine. Okay, so we talked about hepatitis C. You know, I could not do a talk if I didn't talk about syphilis. So syphilis is on the rise. This is not actually funny. Syphilis is on the rise in California and in San Francisco. You can see among cisgender women, as well as people who are pregnant, as well as congenital syphilis cases. And I'm not going to go into the research that we've done in syphilis a lot, but what I wanted to highlight is, again, there are so many opportunities to think about what is happening in your clinical sphere that is missing from the literature. Bless you. And what we saw was that in the literature, there was nothing talking about the barriers to syphilis treatment that we were seeing every day, specifically people experiencing homelessness and people with methamphetamine use disorder. And so we wrote about it, and we talked about how actually you can treat these individuals, and it's important to treat these individuals if you can make your prenatal care accessible. Okay. In addition, Team Lily led me into this world of syphilis. As I said, San Francisco, we are so privileged to work in a very robust Department of Public Health. And the Department of Public Health put together a congenital syphilis prevention task force that has done tremendous work trying to get our rates of congenital syphilis back down to zero, which is what they were for decades before this upsurge came more recently. The work that they have done has included working with emergency rooms to make sure that people test for syphilis in the emergency room, to improve EPIC documentation of syphilis. And I did want to take this moment, this has nothing to do with research, but just to remind everybody that if you ever see this sign in someone's EPIC banner, lost to follow-up, syphilis treatment needed, please pay attention to that because that means that they have untreated syphilis and need treatment. If you hover over it, it will tell you the plan of what to do. That was one of the interventions of the Congenital Syphilis Prevention Task Force. And people around the country were doing all of these different interventions around trying to think about how to eliminate congenital syphilis. What I wanted to highlight was the innovative work that was happening in San Francisco, which again kind of brings up that theme of applying lessons learned from different siloed healthcare to syphilis. And what that was, the way it kind of manifested here, was development of this weekly pregnancy loss to follow-up call. So what is that? What we did was think about, hey, again, in the world of HIV for a very long time, they've been having these little huddles, not little, but these important, brief huddles once a week, talking about people who are lost to follow-up for HIV care and how, in a trauma-informed way, using our wraparound services, we can invite people back into care. What would it look like to think about that approach in the setting of pregnancy? Again, recognizing that in San Francisco, we're seeing all of these people with significant barriers to care, people who are unsheltered, people who have very deep substance use disorders, significant mental illness. what would it look like? And again, sorry, that connects to syphilis because we were seeing an upsurge of syphilis specifically in those populations. So what would it look like to apply that concept of those weekly huddles to this population? So over time, what that developed into is a very similar call structured off of that HIV call for people in San Francisco who are pregnant, facing significant barriers to care, who either had syphilis or who were at risk of acquiring syphilis. And again, our criteria for that were generally being unsheltered, having an untreated substance use disorder or significant mental illness, and we're not making it into prenatal care. We now hold that meeting once a week. You can see the multidisciplinary attendees. This is led by an amazing public health nurse who many of you know named Dana. And what we talk about very briefly, this is not a long rambling conversation, we do it in 30 minutes, is we talk about who is the person, what are their barriers to care, very specifically, who knows them best? Who can provide trauma-informed outreach that understands their needs and offer them the services that they want? And then from a clinical perspective, do they need a point of care syphilis treatment? Do we need to bring Bicil into their tent? Do we need to test their partner for HIV with a point of care test? We try to coordinate street medicine and public health nursing and Team Lily and the public health department so that people don't have clients, don't have 4 different teams knocking on their tent saying, hey, I want to talk to you, hey, I want to talk to you, hey, I want to talk to you, because we know that that leads A, to people shutting down, and B, it's incredibly inefficient. We are currently working on writing that work, but again, that's kind of another example of how your clinical work can lead to research. And this is not research with a capital R, but it is, I think, and what I've kind of really come to appreciate over time, when you don't see a way to solve or kind of approach a problem in the literature or at the conferences that you go to, it's worth putting something out there, even if your data is messy, for people to learn from. And putting it in a kind of publication form allows often other organizations to advocate to be able to do it in their setting. Because if it's not written about, then people say, oh, we don't need to do that. So it kind of holds other organizations and public health organizations specifically accountable. How am I doing on time? Good, okay. Lastly, I wanted to focus for a second on one of the main barriers to care that we see among Team Lily clients, which is fear of having your child removed. Every single one of our patients, whether they've had children in the past or not, walk in our door, and if they don't explicitly say it, they have the thought of saying, are you going to take my baby away, or is the hospital going to take my baby away? That is due to a very long history of hospitals, health departments, intervening and not offering support and leading to separation of families. So much racism and discrimination is embedded in those practices. And we recognize that in order to really reach these patients and clients, we needed to address it. Here, I want to give a lot of credit to Ana Delgado, who has been thinking about how to address this fear for a very, very long time. We are, again, privileged to live in a state that actually publishes our data on child protective services. And what we could see are striking inequities about who is referred to CPS, whose babies are investigated and whose babies are removed. Again, showing the very explicit racism that is happening in our city even today. And Anna asked the very important question, so what does that mean for us as providers? Yes, we looked and saw that our referrals in San Francisco General didn't show inequities by race ethnicity, but we were playing into a very racist system. So we still had to own what we were doing and think about, is there a way that we could prevent any unnecessary referral? So the way that we did that was to develop a care coordination timeout. I'm going to go really fast because we're wrapping up. A care coordination timeout was developed by the pediatric and perinatal equity team at San Francisco General, who you can see the members of there. They developed a pilot, and then we piloted it with clients. The idea of the timeout was to take a pause before any referral to CPS for a couple of different reasons. Number one, we recognized that historically, all of the weight of CPS referrals were often held in one individual's hands. And we recognize that whenever we rely on one individual, there is going to be bias and discrimination. An evidence-based practice to decrease bias and discrimination is to share responsibility and share decision-making and to slow down. So that was intervention number one, to slow down and to make group-based decisions as opposed to an individual making a decision. Second of all, our goal was to decrease unnecessary reports. Third of all, we wanted to increase transparency in how the process happened. In terms of child CPS referrals. And then fourth of all, we wanted to actually use this as an opportunity to offer people support because we were seeing that not everyone in the birth center was being offered the same types of supports. This is what the timeout sheet looks like, just to say it is practicable and usable in busy labor and delivery units, and it is very structured. And I wanted to shout out Tomi, who is a first-year medical student who I'm really trying to make go into OBGYN, but she wants to be a pediatrician. It's really problematic. What she did and what she did with a group of medical students, you can see all of their names up here, along with Heather Briscoe, was to pull all of the data from 2023 to see how this timeout process was working at San Francisco General. What we found, first of all, in this small graph on the right, was that this is a cascade of CPS referrals. So anybody who had a timeout, anybody who had a call to CPS, and anybody who had a child removed from their care. And what we wanted to make sure that we weren't creating new inequities. And I'll just summarize to say that we did not find that any new inequities emerged. What we also saw on the left, when we compared pre-timeout to post-timeout, was that the number of referrals were the same and the number of removals went down. We were really proud of this because over this time period, fentanyl hit San Francisco, homelessness skyrocketed. In most cities, referrals were going up and ours stayed stable and resulted in fewer separation of families. And we think that's because through this timeout process, we've been able to advocate better to CPS for people to understand families' strengths and supports, for us to be able to offer more supports and prevent family removals. Clearly, we have so much more work to do, but the point here being that, again, you see a clinical problem, you think about what your intervention is, and then you research it. Again, the data might be messy, but you have to do it in order to understand if you are making any progress. Our future directions with Team Lily and for research, we have so many different research questions. So if any residents or students want to come help us, you are so welcome. I wanted to appreciate the FOR Foundation, who is funding us to do a larger evaluation of our program over time with qualitative and quantitative evaluation. Specifically, they're also funding a robust client advisory board, which we are calling the TLAB, the Team Lily Advisory Board. I think it's a cute name. And we are really grateful for that opportunity to continue to evaluate our work. Just to close, my reflections from this kind of third pseudo fellowship are, again, being open to continue to learn new things and try new things. I knew nothing about addiction care and substance use disorder treatment, and I learned a lot about it on the fly from my colleagues, particularly in the spaces of HIV and HIV prevention. And it was really fun because, again, it kept me on my toes and helped me to, again, continue to feel invested in my career. Continuing to ask questions about the things you can't find evidence for, listening to your colleagues and collaborators who may have different lenses. And then I think the last piece is to really recognize, I said this in multiple different ways, but to say it again, this work in particular is super, super hard. Surrounding yourself with people who make it meaningful and interesting and fun, at least for me, has been the way to sustain the work, both in terms of clinical work as well as in research. So with that, with 1 minute left, I hope I've shared with you how non-linear my research path has been. And I am going to close with a request for the fellows, which is to, again, just think about this political moment. Science is under attack. We really need each of us, in whatever way it is, either from doing a small evaluation to a massive clinical trial to doing bench to bedside research. We need you to integrate research into your careers, because otherwise we are going to not be left with evidence practice, and we are not going to have future researchers, and it's going to harm all of our patients and us. So this is my daughter, my 8-year-old daughter made me a Mother's Day ship made out of popsicle sticks, which felt kind of appropriate for sailing off into the sunset for you all. So congratulations, thank you, and I'm excited for your abstracts. Trying to skip questions, but if there are questions, I'll take them very briefly.
Just one question, and it's not a hard one. It's just you talking, but I just want to say thank you so much, as you reflected that, you know, we had a last minute change with our invited speaker, and I just can't thank you enough. I think you displayed some imposter syndrome in doing this, but I think we can all agree that you have outdone yourself with your multiple career changes and fellowships, and we just I'm just so incredibly impressed with your work. I just wanted to ask, along the way, you kept on picking up things and projects and you know, most importantly, like clinics that you were running and patients that you were caring for. I'm just wondering how, over the course of then going back to retrainings, you were able to kind of continue running those programs and staying true to a lot of the kind of really meaningful work you were doing with direct patient care.
Great question. I think Tushani put it another way is like, how do you, balance is not the right word, but how do you kind of fit all the pieces together? I think for me, from many points, the pieces didn't fit. And I think one of the pieces that has been important for me has been to kind of share, move on. So for example, right now, Monica Hahn is doing an amazing job running Hive. I'm still connected to Hive and I'm covering for her while she's on vacation. And I am less involved in that work right now, actually, but it's kind of circled back. And I love that now Hive patients who can't make it into Hive Clinic come to Team Lily Clinic. So I get to still continue that care of people living with HIV. I think the other piece is that as I said, there's going to be moments in time where research is high on your list. You have, and maybe that's just because of funding, and you have less clinical time. And then there's going to be time that's vice versa. I think for me, what's been important has just been continuing in those clinical times to recognize that I'm learning and write down those research questions, or at least kind of store them in the back of my brain for times when there is more time. And again, that's done through collaboration with other people. You don't always have to be a PI, you can be a collaborator. And yeah, I think being in an environment like this, where so many people are doing so many different projects, facilitates that. So.
Thank you.